thank you for choosing to spend the morning here with me. My goal and hope and aim for today is just to provide you guys with some information, some stories, experiences, research data, of course, that is relevant and practical and hopefully interesting and engaging for you, and maybe get you thinking about some new things, throw some new perspectives in there, gain some new knowledge, new tools, new ideas for you to be able to use in practice as a case manager and maybe in life as well. So on that note, we have our title slide here, which hopefully you all can see, which is Complex Trauma, Understanding Complex Psychological Trauma, Treatment Implications for Patients and Providers. So, what does this all mean and how might it be relevant, again, not only in practice as a case manager, but also relevant to me as a person, because we're human too, right? And we experience life events, challenges as well, trauma included, and maybe especially recently as healthcare professionals in this pandemic. So before I jump in, I had this little slide where I normally intro myself, but I'm not going to say much because June, you did an amazing job. You said everything. So thank you for that wonderful introduction. You guys heard about my background and experiences and that kind of stuff. I've worked in a lot of different, my path getting here has been quite diverse. I will say I worked in community mental health for a while, in the correctional system. I worked in a neurorehabilitative setting with those who had sustained brain injuries and multi-traumas. And that's where I got most of my case management experience and became really got a deeper understanding of what case management is. And I so value those 7 years in that interdisciplinary rehabilitation setting. I learned so much from working side by side with nurses and OTs and PTs and physiatrists and everybody. And I kind of try to incorporate that because it inevitably became incorporated in my view of treatment and understanding treatment and patient care. So that's part of who I am. So we'll just jump right in here then. And of course, we have our obligatory learning objectives. And basically, I am going to talk today about complex psychological trauma, but I usually just refer to it as complex trauma. But it's really complex childhood trauma. Sometimes that's called developmental trauma, but for simplicity's sake, I'll often just say complex trauma. And we also see complex trauma talked about not related to childhood and development, which is more of a general type of complex trauma. This is kind of a newer emerging thing, but I'll talk about that a little bit too. How it develops, the impacts or carryovers from this, why it's relevant, of course, in the practice of case management and beyond. And then, of course, we can't leave out talking about the elephant in the room, the pandemic. It's been a big part of everyone's life for the last couple of years. And then, of course, lastly, we'll talk about some treatment options for those who have experienced complex trauma, ways symptoms are treated, some evidence-based, some alternative therapies, and just some tools and approaches that hopefully are useful information for you. So I like to start my presentations with this question because it's the question that is most meaningful to me, which is, why are we talking about this? Why is it meaningful? And some of this I've hinted to already. With psychological trauma, complex trauma, developmental trauma, these are unfortunately really prevalent issues in the world we live in, and I'll speak to that throughout the presentation. And because of that, the chances are, and I don't know if I'd even say chances, I would really guarantee that these are our clients, past, present, and future, whether we realize it or not. Our clients have histories of trauma, some of them complex trauma. And they're not just our clients, right? They're maybe our friends, our neighbors, our colleagues, maybe even us, right? So it's important to talk about it because despite its prevalence, this psychological trauma and complex trauma are not often discussed or well known, and I think there's a lot of misunderstanding around them and even stigma or taboo around this topic. And so I think it's important to talk about it to decrease that stigma and to help increase awareness and clarify things so there isn't those misunderstandings. Another big reason is the cost, of course, or I should say costs. So the inherent nature of trauma is that it's damaging, it has consequences, and it's correlated with all these different health issues, physical, emotional, psychological, cognitive, behavioral, and so on. And the costs aren't just to the individual, they're also to the family, communities, healthcare, society, and so on. And of course, they have costs to our outcomes. They have treatment implications. So those are the big reasons that stand out for me. And I'll touch on these as we go through today. And I'm going to try to leave about 10, 15 minutes at the end for Q&A. And I want to give you a forewarning because I get so excited about these topics. I have this tendency to want to give you all the information. And then I have to remind myself that I just have an hour, so I can't do that. So there's going to be some slides that I may go over faster, and I'll let you know which ones they are. And part of them is like, I want you to have the information or jumping off points. So they're in there for that use. But I'm going to talk about and touch on and discuss more in depth the things that are important, and I'm going to go over some of things faster. And it's just my wanting to give you all the information, so you know it at least is in your handouts. Okay, one other thing you'll get to know about me as you hear me speak is that the way my brain works is that I like to start with defining things and then I get into discussing them. So that's what we're going to do first. So for trauma, if we're just talking about the general word trauma, not any specific type, there's not a universal definition. And there's several reasons for this. It's, one, of course, because there's all these different types of trauma, physical versus psychological. Sometimes we have singular events versus multiple ongoing traumatic events. And so what happens is just experts will tend to create their own definitions of trauma based on their clinical experience, based on their discipline, and so on. But generally speaking, trauma, we know it's an event or circumstance that is harmful to us in some way. It might be physically harmful or other. I think it's really important, and this is one of the things I kind of get on a soapbox about when I talk about trauma, is that a lot of times we think it has to be this physical threat to our safety or a life-threatening event, but it doesn't. It can be something that's emotionally threatening, and maybe it's something that feels like a threat to our sense of emotional safety or a threat to our sense of self. It's really anything that causes this great amount of distress. Sometimes I think of it as anything that can trigger that like acute stress response or that fight or flight mode. And if we think about it, there's a lot of things in life that can trigger that aren't life or death. Right? This, for example, public speaking, I think is known as the number one fear, and I get afraid sometimes too, especially when I first started speaking. And so that's not a life-threatening event, but in that moment, it can feel like it, your heart races, you're sweating. And I'm sure we can all think back to moments where we felt that way, and that's our survival response. So it doesn't have to be life-threatening to be considered a trauma or a traumatic event. Okay, going back to defining trauma, it's generally something that has adverse impacts on us. These might look a variety of different ways, and these impacts aren't just quick, they come and they go, they last for some degree. And then again, it can be sometimes one big event, sometimes smaller events, accumulation of, it can be any combination of small, medium, or large circumstances that occur. And I think that can be another thing associated with trauma. The ones we're easier to point at and say, oh, that's a trauma, are the big, maybe like one-time events. So these certainly are traumas, don't get me wrong, like things like a war, experiencing a war, being in a shooting, or, things like that. But then other things that aren't just one big event you can point to, sometimes are harder to recognize as traumas. And I'll talk a little bit more about that too. So what we know for sure about trauma is that it causes us a significant amount of distress, stress. These terms are kind of this vague word that encompass all kinds of things, all kinds of feelings and experiences. And so, stress is first and foremost in an internal state, right? So it's these internal reactions we have, feelings, responses, thoughts, and it's different from a stressor. A stressor are things that are usually external, outside of us, but they're sometimes internal. But they're things that like trigger us, and they vary by person to person. Now, stress itself is this internal response that we have to anything that life throws our way that just disrupts our balance or throws us off. And this is gonna, again, vary from person to person. So stress is a normal, expected part of life. We all experience it. So then what's the difference between general stress or distress and this traumatic type stress that we talk about? And really, it's just the amount. It is the amount, but it's difficult to quantify. So traumatic stress occurs when we have a whole bunch of regular stress that just kind of piles up and overwhelms the individual. And when someone becomes overwhelmed and what it is that does that, again, is going to be so different from person to person. So we define trauma or traumatic events not by the event itself, but by the level of distress that it causes for that person. It's not about what happened, it's about that person's experience of what happened. So again, that's what makes it hard to quantify, because we're all different. So I like this little example here, and this comes from a book by renowned trauma expert, Dr. Bessel van der Kolk, who I'll refer to today often. He gives this example in one of his books where he said, if you have a race car driver, and by nature, his job is dangerous. He's probably been in a few fender benders, maybe, rolled his car before, and they have all this safety equipment. So let's say he's off work one day and he's driving to the grocery store and he rolls his car over, but he's totally physically fine. He may not be psychologically traumatized by that event because maybe he's used to that kind of thing. Me, however, even if I was totally fine, if I rolled my car, I'd likely experience that as something traumatic. So it just highlights, it doesn't matter what the event is, it matters your experience of it. And it's important to remember this because sometimes someone may tell us something and we may think, well, that doesn't sound traumatic at all. They should be fine. Or sometimes we do this to ourselves. We have this voice that goes, oh, it wasn't that bad, or I should be able to handle this, or why can't I just pull myself together? And we're comparing or judging our suffering. And there's a term for it, actually. It's called comparative suffering. But when we do this, we're shaming and criticizing ourselves, and we're blocking our ability to heal and move forward and get better because we're not acknowledging or validating our trauma or our client's trauma. So that's why I like to point this out here. So I want to talk a little bit about traumatic stress and diagnoses for trauma, because there's been a lot of variations, as there is with many diagnoses over the years. So unfortunately, the DSM, which is the Diagnostic Manual for, it says right here, Diagnostic and Statistical Manual of Mental Disorders. This is the handbook that mental health professionals use for diagnosing. This book does not have a diagnosis for complex types of trauma, despite their prevalence. You've likely heard of PTSD. That one is in here, and that is the one that's, commonly referred to or used, and it is a useful diagnosis, but it doesn't apply for everybody. It's not something that goes across the board. So PTSD, this is for someone who's either directly experienced an event, witnessed event, or even heard or learned about someone else's traumatic event, and they find that distressing. They experience it as distressing. And as a result, there's these 4 hallmarks of PTSD. One is re-experiencing symptoms. So that is having intrusive or intense, either visual or just feelings come back that kind of are triggering of the trauma. Avoidance symptoms is the second one. So avoiding either thinking about, talking about, maybe it's avoiding people, places, activities, or sensations that remind the person of the trauma. And then the third one is negative changes in thinking and emotions. And the fourth one is being hyper aroused, or I like the word hyper vigilant. I think it kind of covers it all, just like easily startled, like just think about being in fight or flight mode still, like scanning the environment for threats, you're looking around, jumpy, and so on. So that's what we have for the DSM. But how is complex trauma different then? Well, you know, I'm going to start first and mainly, like I said, talk about complex childhood trauma or developmental trauma. And these are psychological traumas, but they have a lot of impacts. I hesitate to call them psychological because the impacts are across the board, physical, cognitive, and so on. But initially they are, you know, psychological trauma. So if we're talking about developmental trauma or trauma that occurs in childhood, there's not one formal diagnosis or agreed upon definition, but there's some agreed upon characteristics. So the definition you guys see on the slide here is from the National Child Traumatic Stress Network, and it defines it as a child's exposure to multiple traumatic events that occur early in life. And these events cause wide-ranging long-term side effects. And I like to call these carryovers because they're things that begin in childhood, but then end up carrying over with the person into adulthood. And I'll talk more about that. These traumatic events are severe in nature. They're pervasive, so meaning they can be disruptive, or they are disruptive to multiple aspects of the child, and then as they grow into an adult, multiple aspects of their being and wellness. So their physical health, their sense of safety, their stability, their formation of sense of self, relationships, and so on. As such, they're invasive, and they're often of an interpersonal nature, which is what makes them particularly so damaging and impactful, since these events often, you know, they're occurring early in life with a primary caregiver or parent, or within the family of origin. So they're really impacting and shaping the development of that child and can interfere with their ability to form a secure attachment. And this is going to shape a lot of things. So I have this quote here, and I really like quotes. I think they're great at giving us a better description of things. So there's quite a few of them throughout my presentations. This one comes again from Dr. Bessel van der Kolk, who's a well-known leading trauma researcher, has some great books that I'll tell you about later. But he says trauma is something that overwhelms your coping capacities and confronts you with the thought, oh my God, it's all over, I'm done for, you know. And I think this really, I like this because it highlights like the severity and the true terror and this kind of backed into a corner helpless feeling that trauma can bring up for us. It is truly that fight or flight mode. So there is a diagnosis that has been proposed, but not accepted, unfortunately. And this was proposed and created by trauma experts, including Dr. van der Kolk, to describe this type of trauma. So this is called developmental trauma disorder. And they developed this proposed diagnosis because they wanted to create a term that encompassed all of the biopsychosocial sequelae of exposure to this type of trauma, this type of interpersonal victimization that occurs in childhood, because it extends beyond what we currently have, PTSD. So here they have the criteria laid out, and I won't go over in detail, but it is in handouts. And I do have some additional things I will refer to today that I have some additional handouts for. So at the end, I'll let you know how you can access those. Either I can send them to June or Maureen or whomever, or you can email me. But anyways, this is one of them. So I do have the full diagnosis in a handout if you would like it. So it's, of course, being exposed to trauma that is ongoing or chronic, so more than one time, multiple forms. Dysregulation, which is a huge hallmark of someone who's experienced trauma, especially complex trauma. And this can be emotional dysregulation, You can be cognitively dysregulated, trouble focusing, trouble thinking. It can be body or somatic regulation issues, behavioral dysregulation. And the hardest thing is the person has trouble re-regulating themselves, even when they know and recognize like, hey, I'm dysregulated because of a trauma response and there's no real threat, they still can't get out of that state of dysregulation, which is really hard. And then the third criteria is persistently altered attributions and expectancies. In other words, they have distorted views or perceptions of themselves, their abilities, their looks, their worth, and so on. They may see themselves as a victim because they were, right, for a long time. Distorted perceptions of others, of relationships, people can't be trusted, or distorted view of the world. And this happens because the person is experiencing so many circumstances in early life and receiving messages that are forming these beliefs and behaviors and reinforcing them. And honestly, we live in a society and world that tends to reinforce some of these things too. There's messages we get on the media and from wherever, external sources, that will reinforce some of these negative beliefs about self or others. And if you're already getting those beliefs and distorted views in the home environment, they're more easily reinforced when someone hears them from another source. So this can lead to, of course, feeling hopeless, helpless, depression. And then the fourth criteria is functional impairment. So, this can look like trouble functioning educationally, within the family, with friends, legal, vocational, and so on. So a little bit of good news here. When it comes to diagnoses, the ICD-11, which I believe, the last I looked, came out in January 2022, which is just a month ago. This has a diagnosis for complex trauma. So the ICD-11 is used by physicians, medical professionals, you're probably familiar with it, insurance companies. And so they added this diagnosis for CPTSD, or complex PTSD. And I think it's long overdue. So like PTSD, it's saying you have to be exposed to at least a traumatic event. And again, defining a traumatic event isn't the event itself, it's how the person experiences it, right? And then the exposure to that event is repeated or in multiple forms. And this trauma in the ICD-11, which I think is kind of cool, it doesn't specify that it has to come from a particular source. So it doesn't have to be linked to childhood or development. It can be, but it also goes broader than that. And so the criteria they lay out here is the first three are similar to PTSD. So you have the re-experiencing of symptoms like maybe flashbacks or strong emotions related to the trauma that come back, avoidance of trauma, things that remind you of the trauma, hypervigilance. And then they also add these other symptom clusters, which are emotional dysregulation, which is similar to when I talked about developmental trauma disorder, interpersonal difficulties, negative view of self or self-concept, and functional impairment. So it's almost like a combination of those other two diagnoses. I just wish the DSM, which is what mental health professionals use, had a diagnosis that kind of fit in here too. So I think I do have a handout too, if you're interested in CPTSD from the ICD-11 and those criteria. So what factors lead to specifically complex developmental trauma, childhood trauma? And, there are a lot of things here. There are a lot of things that can contribute to this. And I think it's important to speak to them because they're often under-recognized or unseen or normalized. And this can be very difficult as a provider and as the person experiencing the trauma to go, what's going on with me, recognizing these things. So of course, experiencing abuse or neglect is one of the primary factors. And I think, there's abuse and neglect that's more obvious to identify. We're like, that's clearly abuse or that's clearly neglect. But there's things too that aren't as easy to identify. you know, one of the things, if you look at the World Health Organization and their definition of what constitutes child abuse, one of the things they cite is just not providing appropriate level of support or the appropriate environment for a child's development. Well, I mean, that's kind of vague, and it can include a lot of things and not as obvious to point out, but nonetheless, it can still be experienced by a child as traumatic. So examples they give of things that are recognized as emotionally harmful are limitation of freedom of movement for a child, shame, blame, threats, humiliation, intimidation, discrimination, ridicule, mockery, other forms of non-physical rejection or hostility. And with neglect, for example, you know, you might have a child that lives in a great house, a mansion even, right? Has all their needs physically met, food, shelter, and so on, but maybe they don't have anyone that's validating their emotions or showing empathy or connecting with them. And I think it's also hard to identify because I believe that parents most of the time are not trying to hurt their kids. They don't realize sometimes what they're doing. They're either just acting out of what they know or doing the best they can. So it can make it hard to define, you know, what trauma looks like. So again, these are the factors that contribute to it. A big factor is who it comes from. Like I said, you know, the fact that it's interpersonal and coming from a primary caregiver is important because that first relationship that's formed in life is going to be like a building block for how that child interacts with other people and views themselves in the world. So that can have a big influence. And I have this Jenga game here because it's one of the things I thought of with trauma. You know, with Jenga, when you're playing that game, what usually happens is the base or the building blocks aren't structurally stable or sound, and it eventually topples over. And with kids that grow into adulthood that have this history of complex trauma, it's this foundation or circumstances they had early in life that were not structurally sound or functional or secure. And so when they grow into adulthood, often what happens is these carryovers start impacting them. And often they come to us maybe in this state where they're feel toppled over and kind of things are falling apart. The good news there is when they're reaching out for help, it's a great opportunity for growth and change. So that I try to look at the positive side of that. So here we have some other factors that create or, you know, contribute to complex trauma. And this list isn't all inclusive, but I wanted to put a few things here. So patterns of poor communication. So if there is within a family of origin or child environment, there's indirect or manipulative. Oh, I'm sorry. What was that? Oh, did someone say something? Okay, I'm gonna keep going. So patterns of poor communication. And I want to note too, these behaviors, it's not about like this happening one time. Of course, we're all human. And I mean, as a parent, I'm sure I've had set poor boundaries at times or have, you know, been critical at times. It's about it being a pattern of events, like an ongoing, unrecognized pattern that is where it becomes harmful. So it's not like, oh, if you poorly communicated once someone in childhood, that's going to cause trauma. It's about it being a pattern. So having a lack of empathy in the home, judgmental attitudes or behaviors, perfectionism, if you're in a family of origin that has, the environment has unrealistic standards to live up to, control, manipulation, a lack of privacy, enmeshment. And again, I think, maybe this is my rose-colored glasses, but I'm keeping them, is that I don't think that parents do this on purpose. I think often it's without realizing, you know, it's not done intentionally. Either, you know, adults were raised this way or it's been normalized in our society. And often they're trying to do what's best or protect children and having good intentions and not realizing some of the outcomes. So there's a few more here. You know, I wanted to mention these dysfunctional patterns sometimes come with rules or beliefs or behavior patterns that are said. And just to give a couple examples, like a message like, don't air out the family's dirty laundry, which means like, don't talk about what's going on in our family, don't tell other people. And it seems like, okay, like, all right, that makes sense. But the underlying message can be for a child, don't talk about what happens in our family with anyone outside of the family, despite if you need to, despite if you need help and need to talk to someone. The message is protect the family structure. That's more important than how you feel or what you're experiencing, which can be emotionally threatening and experienced as traumatic if it's an ongoing thing. There's lots of messages out there in the world, and especially related to genders, men shouldn't cry, women should look or act or dress a certain way. And they're really, the underlying message is just don't be human, right? Shaming who you are or how you feel or how you look or how you talk and so on. And this is, again, a threat to our sense of self and can cause really dysfunctional coping patterns. Because if we are shamed or told to shove down how we think, act, dress, feel, whatever, express emotions, we feel shame in that. And so then when we're trying to cope with, well, if I can't be who I am, what am I going to do to cope? And we often in childhood, because we're trying to kind of survive that and we don't know anything better to do, come up with a coping mechanism that isn't always functional and then carry it with us throughout our lives. So I'm not gonna, go into too much more detail about this, but I think my point in talking about it is just to show how trauma doesn't always look like trauma. I almost want to come up with a new word for trauma because there's a lot of stigma around that word. And I think trauma isn't, it needs to be talked about more and not feared because it's so prevalent. And because it is feared, there is this layer that's hard to get through when talking to clients or even in ourselves, recognizing some of these circumstances that have impacts on them. But as clinicians, it's really important that we know about and can identify these things and understand them because honestly, I don't think any families without some level of dysfunction, and I mean that in the best way, because we're all human. And if we can identify some of these things, not just for our clients, but for ourselves, and we can understand them, that's where we can make change versus if we continue to normalize or gloss over or, ignore some of these issues, we can't make change. It's reminding me of a favorite quote that I'll share with you from Carl Jung, a psychologist. He says, until you make the unconscious conscious, it will direct your life and you will call it fate. And that's so meaningful in this circumstance. And just, I don't know, in general, this is why I love talking for just that reason. I like sharing knowledge, making things conscious for people as they've been made for me. So I want to take a moment and talk about more general complex trauma, not necessarily related to childhood, because it's really relevant, especially right now during this pandemic. So when the pandemic began, right, early 2020 in March, as a trauma researcher specialist, I started to wonder, like, the first month or so, or maybe week, like, is this trauma? This seems like it might be trauma. And, wondering, is it going to have these impacts on people that I know that trauma has? Now, that seemed like a silly question back in 2020, honestly, it did. But now it seems painfully obvious that yes, the answer is yes. And I've been speaking a lot on trauma, especially with healthcare workers, nurses, clinicians, and have really seen more clear that this fits the bill, this pandemic fits the bill for complex trauma. We know, because there's research and data out now about what ways and how we're being impacted by the pandemic, just in general as a population, but also healthcare workers. We know we're seeing increased levels, up to 90% of healthcare workers are reporting high levels of stress, anxiety, frustration, exhaustion, burnout, depression, compassion fatigue, work-related dread, and so on. And, if you think about how many people, and maybe even us, have been exposed in this last 2 years to at least one event or circumstance that has been really distressing for us and that has had lasting impacts. Maybe it even qualifies for some of those characteristics of trauma, you know, like re-experiencing or avoiding or hypervigilance. I mean, the pandemic has brought with it, to name a few things, just this sense of insecurity, not knowing what's going to happen next, this a loss of sense of security, loss of reliability, loss of predictability, and just loss in so many forms. Loss of life, of course, of being the biggest one, and loss of loved ones, and even, you know, especially in healthcare, just witnessing or hearing about loss of life of people we don't know. Financial loss, lack of resources, and just nonstop change and having to adapt and kind of living in this chaos or fight or flight mode. And, you know, making it even tougher. And it's often our world around us kind of like looks normal, doesn't always look like trauma. You know, we go through our day to day, we get our groceries, we pick up our kids, we do what we need to do, but we feel that trauma inside, and that can be really confusing. It reminded me of this picture here. I don't know if anyone has felt this way. I know I have in life before, and maybe you're feeling this way now, but I say that to normalize that although I don't want you to not be okay, or anyone, it's okay to not be okay. And it's important to recognize if you're not, so that you can make change. So I would say the pandemic in all of its circumstances has certainly has the potential to cause complex trauma for individuals. So, you know, there are a lot of carryovers. That's what I want to move into next, or impacts of trauma. I'm going to go over some of them a little quicker because I want to get to resolutions and tools and approaches. I have a new slide handout for this, I realized, because it might be too small to read, so I can pass that along. These are just showing all of the different impacts of trauma, which, as you can see here, is pretty much across the board, right? It affects us in all areas. And here, you know, we can see there's these emotional, social, behavioral carryovers or impacts of trauma: shame, trust issues, anxiety, depression. There we see an increase in suicidal ideation, an increase in suicide attempts, poor boundaries, chronic pain. So the literature that exists shows this really strong correlation between chronic pain and PTSD in particular. They have a comorbidity rate of up to 50%, which I thought was really interesting, but also kind of makes sense because, you know, as I'll talk about the carryovers, you'll see physically how trauma affects our body. So this is another, I do have the handouts for these, a really great, one's a poem and one's a couple lists of characteristics. And I thought they speak really well to the experiences of individuals with complex trauma. If you're interested in these, you can look them up by using these titles here, or I can pass along the handouts to you or someone at CMSA who can pass those for everybody. I just wanted to include them. So if we look at trauma's impact on the body and brain, we see first hormone level changes. So it makes sense because if someone is living in a constant state of stress and unpredictability, maybe even like with the pandemic, we see an increase in stress hormones, cortisol and adrenaline. And these, of course, can have impacts on our body: elevated blood pressure, weakened heart and circulatory system, disrupts immune system, causes inflammation in the body, increased risk for lupus, MS, increased risk for cancer, and so on. And it can also affect the neural connections in the thinking areas of the brain, which can make it harder for children who are experiencing complex trauma to cope with adversity and kind of figure things out as they grow up. Trauma can cause epigenetic changes, which is interesting. So changes in how our genes are expressed. So, you know, you may have a gene that, you know, or you might be born with the capacity to be tall and confident, but if you're undernourished or abused as a child, this trauma can kind of turn on or off that gene expression. So you may be stunted or fearful as an adult instead, or it can turn on maybe some predispositions you might have to other medical conditions. So I thought that was interesting. There are quite a few co-occurring conditions that correlate with trauma. And I think what's really relative to talk about here is the ACE study, or the Adverse Childhood Experience Study. And basically, this is one of the largest investigations done on the carryovers or side effects of having adverse experiences in childhood. And they looked at over 17,000 participants. And I think some of the most remarkable things they found was that more than half of the people that they asked had at least one adverse childhood experience, some sort of loss, divorce, neglect, whatever. Which I think speaks to the prevalence of childhood trauma. And they found a quarter of people had 2 or more categories of ACEs. They also found that there is this direct correlation, a graded relationship between the number of adverse childhood experiences that someone had in childhood and the presence of adulthood diseases, including ischemic heart disease, cancer, chronic lung disease, skeletal fractures, and liver disease. There's a lot of correlations there. It's a very interesting study, and one that's referenced often in talking about trauma. So some of these I already spoke to, just that there's a strong correlation here between mental illness and developmental trauma. And these are some of the things that are strongly correlated, anxiety and depression being some of the big ones, substance use disorder being another one. And speaking of that, we probably can deduce why that's relevant or how it's tied to trauma. And there's plenty of data and studies to back that up, this high correlation between history of complex trauma and addiction. And this can be for multiple reasons. Sometimes or often substance use or addiction develops as a way for the child or adolescent to cope with the trauma. Sometimes it's learned behaviors. And it's not just substance addiction that comes into play. It can be what's called process addictions or behavioral addictions, which is basically being addicted to a behavior or to doing something. And similar to a substance addiction, the individual can't stop engaging in that behavior despite the harm that it's causing them. It's compulsive. And so I have a list here of common ones. We probably know what these are, right? Workaholic, gambling, social media, exercise, anything that's done compulsively. And another couple of things that it has in common with other addictions is that the individual often finds it psychologically rewarding when they engage in this behavior or kind of get a high or dopamine while doing this thing, but later might feel guilty or remorseful when they did that because of the consequences. So here's another quote for you, and I won't read it, but it is in your handouts. And this is just from about process addictions. And one other thing I want to mention here is trauma blocking, the idea of trauma blocking. So trauma blocking is this term or concept used in this realm, complex trauma, and it's when a person is engaging obsessively in an addictive manner, either with a substance or with a behavior, and what they're trying to do, it's an effort to block out or like overwhelm the painful feelings from the past or from unresolved trauma. They're trying to escape or numb or avoid how they're feeling. And it reminds me of this quote again from Dr. Bessel van der Kolk, and he says, trauma comes back not as a memory, but as a reaction. And so what you're doing with trauma blocking is trying to avoid feeling the reactions that are uncomfortable that are coming up in that moment that are rooted in the trauma that the person has experienced in the past. So they're essentially trying to cope with it by running from it or running from how they're feeling inside. Another little quote here for you. And then a couple other things of how trauma affects the brain. I think the most interesting is the changes that it makes to the amygdala. So our amygdala is where our emotional center or fight or flight, and trauma sensitizes, like oversensitizes the amygdala to the perception of threats because it's constantly being touched on. With complex trauma, it becomes hypersensitive. So what we see are children and adults often reacting or overreacting to triggers that are maybe minor or don't call for that. It's this hypervigilance. So that's one of the big things that we see that is very difficult it's a change in the brain. And working in brain injury for a while, I couldn't go without showing you this lovely little diagram of the brain and, the lobes and functions and what's all encompassed there. So, okay, I want to move right into treating trauma. How do we help people who've experienced trauma, who often have just lived their lives in survival mode? How do we help them thrive? Okay, the first thing I want to speak to after I have some water here is the importance of taking a holistic or functional approach. And this is really, looking at the whole person, their emotional, spiritual, physical, cognitive being. And again, I think my experience working in this interdisciplinary environment for all those years really helped me get a better view of what that is and what functional medicine is. And many of you may already do this, but I know sometimes we can get stuck in like our discipline or looking at one aspect of treatment versus looking at the whole person. So this is really an important thing. Okay. So in treating trauma, it's important to find someone who's trained in it, obviously. So ask the questions. There's various certifications out there, various approaches. Case managers are good anyways at advocating, and that's our ethical responsibility, right? Like finding someone who is appropriate to treat trauma. And I think there's more and more trainings out there, so it's coming more and more to the forefront. So the most common used approaches in treating trauma are psychotherapy and counseling, and this can include CBT, DBT, exposure therapy, relaxation training, and so on. And the goal here is really self-regulation, gaining a feeling of safety, because often those with trauma haven't felt safe in their life. Improving self-worth, view of self, increasing functionality, helping them regulate, of course. And it's often strength-based, so really helping the person focus on the strengths they do have and reframe, again, their view of themselves, building self-esteem, self-efficacy, self-worth. Medication is used often in conjunction for treating the symptoms. But I want to talk a little bit about psychotherapy in particular. Cognitive behavioral therapy is often used, and this is a type of therapy where, we have the definition right here, but I'm just going to give you how I like to think of it because I think it breaks it down a little bit better. Basically, I like to think of cognitive behavioral therapy as an approach that considers just the interconnectedness between our cognitions or our thoughts, our feelings, and our behaviors, how we act. And the underlying premise there is that if we can approach treatment from one of these angles, our thoughts, our behaviors, our feelings, then if we can modify or influence one of them, they're going to influence the other one because they're all interconnected. So CBT approaches sometimes use thought work approaches to help people, because people with trauma, as I said, often have distorted beliefs or perspectives that they internalized from childhood about who they are, what the world is like. So you're helping them identify some of those thoughts, lay them out there on the table and say, is this thought true? Or is there a more realistic thought? Is this thought supporting anxiety or depression? Is there a thought that feels better to you that's more true again? CBT also includes behavioral interventions, so ways a person can change their behavior to influence their functionality and how they're feeling and thinking, and then emotional work, so processing feelings and so on, or some combination, often a combination of those. I'm going to go, there's some more quotes here, of course, which you can read through, but this is just really talking about the fact that more and more research is showing trauma is not just a memory up here. It is stored in our body as well. And there's some really great books out there. They're in the handouts. One's called The Body Keeps the Score, and the other one's called Waking the Tiger. And they're written by trauma experts, and they speak to the fact that it's our body that reacts to trauma often. I love this quote again from Dr. Bessel van der Kolk. It says, trauma doesn't come back as a memory, comes back as a reaction. And I think that's part of what makes trauma so hard to identify at times, because it's not like the person's like, oh, I feel this way because of this trauma that happened 20 years ago or whatever. That clear connection isn't there. It's more like they're triggered without realizing it, and emotions come flooding back, and all of a sudden the person feels panicked or afraid or overwhelmed, and they don't know why, and then often reacts in that moment. And it can be very confusing. Oh, excuse me. So, little review here of our sympathetic nervous system, which again, it's this fight or flight response. So I'm not going to go over these in detail, but we know that when we feel threatened, we have this fight or flight response that turns on. You think about back in the Stone Age, it helped us survive, right? If we're faced with a lion or a tiger, this system kicks on and helps us escape the situation. And today, hopefully we're not faced with lions or tigers, but we still have the same responses, but they can look a little different. So I thought this slide is helpful in looking at what this fight or flight response can look like in this day and age. So fight isn't necessarily like, fighting. I hope it's not anyway. I guess sometimes it could be, but it might look like being aggressive or controlling or demanding perfection or being a bully or being hypercritical. Flight doesn't always look like running away from a threat. It might be cognitively flighting by using drugs or alcohol. It might be engaging in obsessive compulsive behaviors or over worrying. Freeze response is kind of like playing dead. But today it may look like depression or detachment or isolation. Fawn is a survival response and kind of like, I'm going to convince the tiger not to eat me or please it in some way. But in this day and age, again, it looks like people pleasing, not standing up for yourself, just trying to keep the peace at any cost. So those are what some of the trauma responses look like. And I have this here because, that fight or flight system obviously is within the nervous system. We feel it throughout our whole body. And so a lot of healing trauma is about healing the nervous system. This is what a regulated nervous system is like. Whereas if you have trauma, as you can see, the nervous system tends to be dysregulated. So we either get stuck on, meaning hypervigilant, but we can't stay there forever because that's exhausting. So we can end up being stuck off, right? Like being down. So if you read this slide, stuck on, again, anxious, hypervigilant, we remain in this mode because we're panicking, but then we can't stay up there forever. We're human, we don't have the energy. So then maybe we crash and we feel low or depressed or, fatigued. And we may see this pattern in clients or maybe experience it, especially again through this pandemic. So one type of trauma treatment that's been developed to address the bodily and the nervous system response and help discharge that emotional energy that gets stuck in the body from trauma is called somatic experiencing. And this was developed by Dr. Peter Levine. And again, that book, Waking the Tiger, he wrote. So he has a website on this that you can learn more about it. And this is an alternative therapy, but there are some randomized controlled studies done on its effectiveness that were from 2017 for treating trauma that showed really positive results. So I thought it was something worth sharing, and it's something that's being talked about more and more. The Body Keeps the Score speaks to this also. I want to talk about EMDR for a minute because this is a great trauma treatment option that's becoming more and more into the forefront. So this stands for eye movement desensitization and reprocessing therapy. And this is a type of therapy that basically helps people become non-reactive to the effects of trauma. Because if you remember, trauma doesn't often come back as a memory, but it comes back as a feeling or a reaction. And so what EMDR aims to do in the safety of a psychotherapy session is to help the individual kind of recall, not to a degree that's re-traumatizing, but to a degree that feels safe once they've built a relationship with the client. Some of these reactions are memories, and they're recalling them in an environment where the emotions come back, but they're staying grounded in the moment with the therapist so that they can reintegrate these reactions and these memories so that they're not so reactive to them. with the overall goal being to decrease reactivity. Because what happens when someone experiences trauma or multiple traumatic events is the brain isn't, it's in fight or flight mode. And when that happens, all processes, or most, all energy goes to survival. And the things that aren't necessary for survival tend to go on hold. And processing memories is one of them. So normally we would take our thoughts, feelings, descriptions of an event and process them and integrate them and put them away nicely in a little file cabinet. That's how our brain works. But when we're in the midst of a trauma, that part of our brain isn't working well because our brain's worried about survival. And so what happens is you have these fragments of feelings and thoughts and memories and reactions associated with the trauma that are kind of just floating in there, and then they get touched on throughout life and the person becomes reactive, but they don't necessarily know why. So EMDR is trying to reintegrate those things and put them in the file cabinet where they should have been so that the person isn't ruled by them anymore. They're not floating around. They're not being touched on. So that's my little description of that. I want to say there are skills and tools that can be so useful for those who've experienced trauma. And this is not in place of professional help, but they're things that are either done in conjunction with professional help, or if it's something where it's not traumatic stress, but maybe regular stress, they can be useful. And we've probably heard of grounding exercises. And for those, people who are traumatized can easily get triggered, like I said, or overwhelmed or emotionally flooded. And so grounding is anything they can do to help bring you down into the present moment. So I included, and this again is me trying to give you all the information. I have some grounding exercises in here that you can read through. I love this one that is just speaking yourself into the present moment. That looks like, my name is Stephanie Hune. I'm sitting right now giving a presentation to a wonderful group of people at CMSNE New England. It is 9:14. I'm going to wrap up soon, don't worry. So there's time for Q&A, but you're just saying the truth of what's here and right now to bring yourself out of this chaos and into what's true in the present. There's a couple other examples here I included for you: a chair grounding exercise. Breathing is a really great way to ground yourself and regulate the nervous system, especially if it is done in a particular way. So this is diaphragmatic belly breathing. And what you're doing here is breathing in through the nose and out through the mouth, but you're filling the diaphragm with air, which literally is touching on the muscles are touching on your nervous system and forcing it to downregulate. So this is a really good coping skill. And I included a couple breathing exercises in here. So let's move lastly, and I'll just take a couple minutes, and some of this is a review that I've already talked about. So tools for case management in treating, those with trauma. So one of the most important things I think we can do is have a trauma lens, look through a trauma lens. And we have this definition here: being sensitive to the impact of others. Basically, a lot of it is doing what you're doing right now, learning and being open to and gaining awareness of what trauma looks like, where it can come from, what are some misconceptions about it. I think it's under-recognized and can be stigma and taboo around it. I think of a trauma lens kind of like this knowledge or perspective, or this look, as the slide has this glass where I have in my back pocket where you can pull it out and you're looking at the client, or again, maybe yourself as a provider, or, somewhere else in your life, looking through this trauma lens, having this awareness in the back of your mind of, does this line up with trauma? And it's, again, important to recognize that so we know how to proceed with treatment. And that's our ethical, duty and responsibility is to have this awareness, because often, and this happens a lot with those who've experienced trauma, there's misdiagnosis. A lot of individuals who have experienced childhood trauma, complex trauma, are diagnosed with borderline personality disorder, other types of personality disorders. And therefore, treatment may not be the treatment method used may not be what's most appropriate. And then also, I think when symptoms and behaviors are misunderstood, it can reinforce some of the negative feelings and behaviors that the person has, which we don't want to do, right? That's another one of our ethical responsibilities. We want to do good, do no harm. So trauma-informed care, likely something you've heard about before, TIC. By definition, this approach, which I think is so interesting, this is an approach that assumes a person is more likely than not to have a history of trauma. I thought, wow, finally we're realizing the prevalence of trauma, just by definition, right? That stood out to me hugely. So having a being trauma-informed and providing trauma-informed care and having this lens is having the knowledge and assumption that that person in front of you, no matter who it may be, is more likely than not to have a history of trauma. That resonates with me. That's pretty big. So I wanted to include too what the 4 R's are of trauma-informed care. The first one's realize. So, this looks like, again, what you're doing right here, right now. You're learning about trauma, you're improving your awareness, making intentional efforts to use a trauma lens and continuing to educate yourself and learn. Recognize is the second R. So again, looking, what does trauma look like? Being aware of that. Asking the right questions. So when we're meeting with a client, doing a broad psychosocial assessment, asking specific as well as open-ended questions and asking them again and again. I don't know if you can relate to this, but I don't know how many times I have said, do you have any history of trauma or abuse? And the answer is no, 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 no. And then as I go along, the answer turns out to be yes, 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 yes. And it's not that the person was lying or intentionally trying to mislead me. It's often that they don't recognize the trauma that they endured, or there's maybe fear about talking about it. Sometimes there's denial. Often there's denial, kind of as a protective measure. So being able to recognize trauma, even when the other person can't recognize it, and then responding, right? Using this information you have and information you'll continue to gain about trauma to put it into play in your practices and policies, procedures, and so on. And then the 4th R is resist, which I don't love this word resist. I think they picked it because it's an R, but I feel like resist means like we are resisting the impulse to re-traumatize someone. Like we really want to, but we're going to hold back. I don't think that's true. I think a better word might be avoid re-traumatization. But anyways, it's just being aware of and vigilant to not re-traumatizing a person. And I think that this can happen really easily without realizing, not being intentional. I think, the same thing with clinicians. We went into this field because we care and we want to help people, not because we're here trying to hurt someone, right? A lot of the ethical kind of violations or, such as re-traumatization occur not because we mean to, but because we're not aware of maybe the outcomes or consequences of how we might be acting or engaging with the client. So, for example, if you have a client that had trauma from the past, from a parent, and within this trauma, they were always invalidated, or their boundaries were always violated, or their personal space was violated. If you are not aware of your own boundaries and maybe have not good ones, you can unintentionally re-traumatize or trigger that client. If the client tells you something like, I'm upset about this, and you go, oh, that's not that bad. Or, oh, you're sad about that. You shouldn't be sad about that. That can be re-traumatizing by, again, invalidating their experience or their feelings. If you're hugging or touching a client, even if it's in a professional sense, without consent, and I don't know if there's professional hugging or touching. I know some people do that. I tend not to, but, that can be re-traumatization, or pressing questions with a client that they've told you they're not comfortable talking about. And I'm just going to keep talking because I don't see any questions in the Q&A right now, but guys, feel free to enter them in there if you have any questions, and I'll stop and address those. But otherwise, I'm just going to keep talking. So, because I know we have about 8 more minutes. So I want to move and just briefly talk about motivational interviewing. I'm going to talk about it in the next seminar too, but this is a collaborative, goal-oriented style of communication, and this can be really helpful with all clients, but also with clients who've experienced complex trauma, who have a hard time with change, because the idea of motivational interviewing is trying to elicit change within someone, while also, being person-centered and being respectful of their autonomy and what they want, and just helping guide them towards change that they desire, not that we're trying to manipulate them into doing. It's helping them move towards their goals. So there's a lot of tools encompassed in this, and motivational interviewing, as I'm sure you have to, you've seen, is it can be a whole seminar in itself, but it's based on the stages of change. Oh, I see one question there. Yep, I will save time for that. So the stages of change are theorized, that everyone goes through these 5 stages. Oh, let me switch my slide here. So pre-contemplation, not even thinking about change, contemplating change, preparing for change, ready to make change. And basically, there's a lot of different tools you can use. I want to speak briefly to developing discrepancy. So this is when it's a tool we can use where we're purposely shifting the focus of our conversation with the client, and we're trying to evoke or point out the difference between what they're doing now and what they said their goals are, and not in a way like judgmentally. It's always with non-judgment, but saying, I see, helping them recognize this difference. Like, I see that you are doing this, which you say you enjoy, but also it kind of conflicts with what you said your goal is. And that can help get them thinking and promote change. Rolling with resistance is another really great one. So, with a trauma client, or even really ourselves, there can be resistance to change because change is hard. But rolling with resistance, I love, because initially our thoughts can be, if someone's resistant, we want to go, no, let me tell you why you should do this, or why you should make change, or why you should think how I think. But when we do that, what tends to happen is that the person pushes back, right? They tend to push back. And so rolling with the resistance is about meeting the person where they're at. And really, what other choice do we have? When we're going, I hear you. I hear that you're hesitant about this. I can empathize with that, and kind of reflecting back to them that, and telling them that you're accepting. I have a couple more tools here, but I'm going to talk about some more. And I also am going to talk about this in the second session, the value of the therapeutic alliance, but this is just the value of the therapeutic relationship. I'm going to stop for a second now, and I want to address this question. So a treatment is basically just CBT. So no, but that is a big main part of it. So basically, CBT is the evidence-based, because it's been around for a long time, right? That's what is evidence-based for trauma treatment, and that can include a lot of different things. I wanted to mention a few tools to you. One of them is thought work. That is a huge one, and that is part of cognitive behavioral therapy, which is helping, again, the person identify, challenge, and replace really distorted thoughts, because our thoughts, as we know, which are usually a statement or belief, directly impact how we feel, and how we feel then directly impacts our behavior, and then they tend to feed into each other. So if we believe, hey, I can't do anything right, we're going to feel bad about ourselves, or angry, sad, depressed, so on. We might isolate or use substances, which is then we're going to feel worse, and then we're going to say, oh, see, I can't do anything right. It reinforces it. So you help the person through thought work get out of that cycle that was induced by trauma that formed those beliefs. So that's part of it. Okay. So benefits of EFT or tapping therapy. Yeah, I'm just to finish. It's not just CBT. That is the main evidence-based one. And that, again, can include a whole bunch of different approaches. There's the thought work approach. Mindfulness and grounding skills are helpful in treating trauma, which fall under behavioral therapies. There are kind of newer alternative therapies, because there's not the data behind them yet. And those are the bodily approaches that I mentioned. So somatic therapy, those can be things like yoga. And again, I'll show you the books at the end of this that'll speak a little bit more to that. EMDR is coming more and more into the forefront, which is a version of psychotherapy that does have evidence behind it that's proved useful for treating trauma. So EMDR is another form of treatment. And, so CBT is kind of this umbrella. And basically, those are the main things that are out there. Sometimes exposure therapy is used, but that's used more for like one-time traumas. Like if someone was in a car accident, isn't afraid of getting back into their car, they might expose them slowly to getting used to that. So there's a ton of treatments out there. I tried to mention the ones, that were evidence-based, relevant, and then some of the alternative ones too. The benefits of EFT or tapping therapy. So this is another type of therapy that what it's doing essentially is down regulating the nervous system. So when we talked about the nervous system, we have on, the too high end, we have our sympathetic nervous system response, which is like hypervigilant, panic mode, fight or flight. And then down here at the opposite end, we have this parasympathetic nervous system response, which can be known as like the rest and digest response, but it also is like low, right? If you stay there too long, it's depression and fatigue and flat affect and that. And so we don't really want highs or lows, right? We want this like regulated. And of course, we're human. We have some little ups and downs with our nervous system throughout life, but we don't want it like this, right? So with tapping, it's tapping into, ironically, being able to regulate the nervous system through sensations in the body. And I'm not trained in EFT or tapping. I've done it before. So I don't know, the technicalities about it, but that is, parts that I do know about it. And it's grounding, it's bringing the person, and this is huge for those with trauma, bringing them out of their trauma reaction. Because remember, trauma doesn't come back as a memory. It comes back as a reaction in the body. It's bringing them out of that reaction, which is often overwhelming and feels emotionally flooding, back down into the present, where they can send the message to their mind and body. I'm safe, I'm calm, it's okay. The trauma isn't happening now. It's a response from the past. So that's what they're trying to do. This is a great question, tips for finding, I'll just answer this super quick, available therapists. I think Psychology Today is probably my favorite go-to resource. And what you can do is go to psychologytoday.com and go to find a therapist. And then it says search by area. So type in a zip code. And then from there, you can filter. There's all these filters. You can filter by specialty, so trauma. You can filter by the type of treatment they do. If you want someone who does EMDR or someone that does CBT, you can filter by insurance type, by gender, by all these different things. And you can go through and read bios and profiles and see if people are taking new clients. I know it's so hard to find therapists right now. We are definitely in a mental health crisis. But I think that's a good resource, and just, calling and getting on a waiting list if you can, asking the right questions. And I just put this slide up here because these are some of the books I was referring to. The Body Keeps the Score by Dr. Bessel van der Kolk is a great one. This one, Healing the Tiger by Peter Levine. These are all in your handouts. And there's a few more here. And I think that's all the questions, and it's 9:31. I'm sorry, I went a minute over.
That's okay, Stephanie. This is June. Just really quickly, there is a question in the chat.
Oh, okay.
Can you see that? And then, yeah, and we are getting close to the next session.
Yeah, no problem. So simple methods to offer parents when a child is having a panic attack. Okay, so that's a big question, and I think there's a lot of variability around like a lot of dynamics to answer that question, like about what's going on with the child, what's triggering it, why are they having it, is it medical, is it psychological, is it environmental, and also, by definition, a panic attack is where the child's experiencing that life or death situation. Their mind and body, whether the threat is real or not, believes that they're in real danger and that they're going to die. So often what can be helpful in the moment is, I think a lot of it is assessing the situation, but really trying to induce safety, a sense of safety and control. And sometimes that's environmental controls and the parent putting boundaries around the child. That may look like, we're going to stay in the house. We're not going to leave this room. Maybe sometimes it's physically holding them. It's going to vary, but from child to child. But I would say, if I had to say it simply or generally, doing whatever is possible to let the child know that they're safe and okay, and that you're present with them and calm, you're not leaving them, and showing them you're calm will then reinforce that to them, that it's okay to be calm and that they're safe until they get through it. Because panic attacks, they come and they go, you know, they don't last forever. So being present with the child through that is probably my best advice there.
Great, thank you for that. And so there is one last question, and are you taking clients at this time?
You know what, I have a wait list right now, so I do see clients and I am keeping a wait list, but I will say too, with state laws and licensure, I can only practice in the state that I'm licensed in, meaning that I have to be present in the state of Michigan and the client has to be present in the state of Michigan. So I have thought about, you know, alternatives to that, but right as it stands, I don't know if it's as relevant, only because unless your client's in Michigan, I don't know that it would be an option, you know, so yeah.
One last question jumped in, but no, maybe not. Okay.
Oh, I see this, education resources who have children who suffer from trauma and have negative feelings. Yeah, you know, I have to say I work mostly with adults. And so I'll have to think about what type of child resources I have. A lot of the resources, and they're in the handouts again, you know, there's a ton of books, and these are some apps that are really great that you can look into, that are mental health apps that have been approved by the APA, American Psychological Association, and they aim at treating a lot of the symptoms I discussed. But these books are great for parents. I like this Healing the Child Within, and really just helps give insight overall. But yeah, I have to think about if there's any one specific to children. My focus in trauma treatment has been mostly on adults who were children who are dealing with these issues. So yeah, sorry, I don't have more on that.
Well, thank you so much, Stephanie, for your first session. It was really outstanding, and I'm sure and I know I do really appreciate your insights into this relevant topic. Well,